This is Dr. Bodine, and we're going to be discussing thyroiditis today. So let's go over some basics on thyroiditis. I recall in school this being a confusing topic, and it's because every resource uses a different way to categorize the diseases that fall within this topic. So I could make a few different slideshows on the different topics, but I went ahead and decided to just kind of do an all-encompassing lecture. So thyroiditis, the thyroid, right? Itis is inflammation. So this is a disease of inflammation of the thyroid gland. Now, various resources will categorize these according to suspected etiology, the actual pathology, or clinical features. So the nomenclature has some controversy, and again, it has to do with categorizing the different forms of thyroiditis. Most thyroidologists will use, let's say, subacute thyroiditis to apply to one specific disease. So this is the group known as subacute granulomatous thyroiditis. They may refer to infectious thyroiditis, which you also can hear suppurative thyroiditis. So there's multiple names for each of these that makes it more confusing. I'm going to just group these into two separate categories. Inflammatory, okay, or often referred to as painful thyroiditis, which includes subacute granulomatous thyroiditis. This includes probably the most commonly referred to one is de Quervain's. Another form is giant cell thyroiditis, and then of course an infectious or suppurative thyroiditis. In this category is also radiation-induced thyroiditis, and then we have our autoimmune states. So autoimmune thyroiditis, and so these are often referred to as painless thyroiditis. Hashimoto's thyroiditis is by far the most common form of autoimmune thyroiditis. It's also referred to as autoimmune or chronic lymphocytic thyroiditis because there is lymphocytic infiltration of the thyroid gland. Included is postpartum thyroiditis and painless or silent thyroiditis. You can kind of think of these almost as the same disease state. Of course, postpartum is going to be only females that have this problem. There's drug-induced thyroiditis, and then renal, which is a fibrous thyroiditis, which could actually be painful at times, but because it is largely an autoimmune-related disease, I went ahead and placed it in the autoimmune category. Now, the ones that we have bold here we're going to spend the most time on, and really the least time with the renal thyroiditis because it's so rare. As you can see, so this is from Up to Date and how they kind of categorize thyroiditis according to the presence or absence of pain and tenderness, and that's how I formed this lecture. But they also include some of the synonyms or causes of the different disease states. I thought that was helpful. So in terms of epidemiology, you can see that almost all of these disease states of the thyroid have a very large female preference. So between 4 and 7 to 1 compared to men. Okay. Just to briefly jog your memories here, I just want to remember that the regulation of thyroid hormone is done via a negative feedback loop, okay? You may recall that the regulation of thyroid hormone is one of the most simple cycles to remember because it has only a few of our organs involved. So TRH is released from the hypothalamus, which causes the anterior pituitary gland to release TSH, which subsequently stimulates the thyroid secretion of T4 and T3 by the thyroid glands. Okay, so inside our thyroid glands, we have all these follicles, and the synthesis of thyroid hormones requires iodine, right? We need to ingest iodine in food, and within the follicular cells, the creation of an organic iodine, so the organification occurs using thyroid peroxidase. So in any case, mostly T4 is secreted, and 85% of our T3 is converted from T4 in the liver and other tissues. Okay, so most of this is extrathyroidal peripheral conversion, and T3 is the active metabolic form. Now, most of our circulating hormones are bound to proteins. Okay, so 99% are protein bound. So if you want to get an accurate measurement of your patient's T3, T4 levels, you need to get a free, so an unbound level to correctly interpret their true levels. And again, there's mostly a negative feedback suppression of our TRH and TSH. So what is the etiology of thyroiditis? Well, I'm going to break these down again by the inflammatory kind and then the autoimmune kind. So we'll start with our inflammatory. So these are our painful thyroiditis, and this is associated with generally post-viral or associated with post-staph and strep infections. Okay, so our subacute granulomatous thyroiditis, this is viral, and this is going to be relatively self-limited. And then the infectious or suppurative kind, they may be bacterial, fungal, parasitic. Most commonly are going to be associated with a strep or staph infection. And then there can be a radiation-induced type, but for the most part, you're going to see the patient is coming in a post-viral state. In terms of the autoimmune, painless thyroiditis, these are grossly painless. Again, Hashimoto's thyroiditis is going to be the most common, and this has to do with the autoimmune process of this has to do with antithyroid antibodies that are produced somehow in response to an environmental antigen, and then it cross-reacts with the thyroid protein. So there's some sort of molecular mimicry, if you will. Precipitating factors can include infection, stress, sex steroids, pregnancy, iodine intake or lack thereof, and radiation exposure. There's a common association with autoimmune disorders and also genetic associations, specifically Turner syndrome. There's a 15% chance of developing this before the age of 40. Postpartum thyroiditis. This is, an autoimmune induced discharge of preformed hormone from the thyroid. It's thought to be of a variant of Hashimoto. Painless or silent thyroiditis. This is very similar to the postpartum mechanism, except it can obviously happen in males, where postpartum thyroiditis is only in female sex. And there's drug-induced, and one of the most common, I think because the drugs are more common, so amiodarone and lithium are probably two big causes of this, and we need to be screening our patient on any of these medications regularly for the development of hypothyroidism. And then renal, which is fibrinous. This is associated with systemic fibrosis, particularly. So usually somebody presenting with this will already have an underlying disease state. So what are our risk factors? Well, if we go back to our etiology, risk factors are going to be fairly intuitive. So the subacute granulomatous thyroiditis, or dequervins, are going to be associated with recent viral respiratory infection, and there's a higher risk with the HLA-B35 serotypes. Infectious suppurative thyroiditis, congenital abnormalities, particularly people at a little bit later in life or immunosuppressed states tend to have this at a little bit higher rate. So it's a risk factor, a history of autoimmune disease, or a personal history of diabetes, or high iodine intake or cigarette smoking can put you at risk for Hashimoto's. And then radiation induced seems fairly straightforward, but risk factors for all of these is going to be female sex. And of course, with postpartum female sex, but having smoking and having multiple spontaneous or induced abortions. And then silent thyroiditis, this is going to be more prevalent in iodine deficient areas. So when we think of diagnosing, we want to first take our history, right? This is with everything that we do in medicine. And so our history taking is with the different forms of thyroiditis is going to correlate with our suspicion of diagnosis. So if somebody is presenting with an inflammatory or painful thyroiditis, they're going to have, could be sudden or gradual onset of this painful thyroid, but they're going to have a preceding upper respiratory tract infection or viral illness. So I diagnosed one of the nurses I work with this. I knew she was out the couple weeks before with strep throat, and she came back and said, "Oh my gosh, Katie, it hurts to swallow. Oh, this, like, my throat hurts so badly. I think I have strep again. Will you take a look at it?" And immediately I kind of, I could see her thyroid was a little bit, it just was a little bit more prominent, and I felt it, and she just jumped, and she's, "Oh, that hurts." So her actual throat didn't hurt, it hurt to swallow. She was still having some fevers, and she thought maybe it was, she was incompletely cured of the strep throat, but what she actually had was subacute thyroiditis. So, and she did end up having some hypothyroidism later, so it's pretty interesting. So anyway, these people will have these preceding symptoms if it's a severe case. So if it's particularly suppurative infection, they will be febrile, and you'll have some complaints of radiating pain, like, "Oh, maybe my ear hurts," and maybe they're not putting it all together. For painless or silent postpartum or subacute thyroiditis, we are going to have kind of a classic triphasic course. And so their history may be symptoms of having some thyrotoxic symptoms. My heart was racing, I was sweating a few weeks ago, and now I just can't seem to wake up. I'm tired. So symptoms of hypothyroidism, and then they're okay. Other historical clues are going to be, again, your symptoms of hyper or hypothyroid state, or both mixed in a shorter period of time. Over here to the right, I have a picture from Up to Date, and it just goes in a little bit more in depth on the timeline you can expect for these painless or subacute postpartum courses, and these are characteristics. So if you're having a patient describing their symptoms over the course of months, that will clue you in to the diagnosis. So in terms of diagnosis, we're going to get our H&P, as we do with all patients, be really thorough, get a thorough review of systems. We're going to be examining the patient, feeling the thyroid, evaluating the symmetry for nodules, and looking for signs of dysfunctional thyroid. And then, of course, we won't forget about our vital signs. We'll make sure that they're afebrile, or if they have a fever, we'll take note of that. Look for recent or I'd say subacute weight loss or gain. And then I'm going to go ahead and break these down again by painful or non-painful. So in our painful or inflammatory thyroiditis, these people with subacute granulomatous thyroiditis are going to present with an acute, painful enlargement of the thyroid gland. Okay, oftentimes, again, there's dysphagia involved because it's tender, but it's actually not their throat, it's their thyroid that's causing the pain. They may have some pain that radiates to their ears. They may have some low-grade fever and fatigue, and the manifestations will usually persist for a few weeks or up to months, and it can be associated with malaise. And then they may even have some subsequent hypothyroid complaints for 4 to 6 months after. But generally, this is a self-limiting disease. Signs of our infectious or suppurative thyroiditis, this is actually pretty rare. So they come in high fever, painful, red thyroid. They might have some fluctuation. You may suspect, maybe there's an underlying abscess. I've actually never seen this. Okay, so in terms of our painless or our autoimmune thyroiditis, what are the signs? In Hashimoto's, again, this is the most common form of thyroiditis. 90% of these people might not even come in complaining of this. You might just pick up on this on exam. So they will have a symmetric, diffusely enlarged, painless goiter. Okay, now it may be firm or have a rubbery texture. And many of these patients will also have symptoms of hypothyroidism, i.e. fatigue, cold intolerance, weight gain, everything is slow. But they could present in the acute stage, which is their thyrotoxic state. So that's heat intolerance, weight loss, heart rate is rapid, okay? And this is because of the release of thyroid hormones during the inflammatory phase of thyroiditis. And this can also coexist with Graves' disease, okay? So oftentimes this will present again in the hyperthyroid state if there's coexisting Graves' disease. In terms of the postpartum form, again, this is thought to be a subacute form of Hashimoto's, and it occurs after pregnancy. So the condition begins in the postpartum or post-abortive period, okay? Usually within 12 to 16 weeks. It's also called, it's related also to silent lymphocytic thyroiditis. So this is the silent form. It's subacute. It's not related to pregnancy, but it's going to have a similar course, okay? So they will present with symptoms of, may or may not present, actually. It could get missed because the hyperthyroid phase is just a few weeks. But then usually this is picked up 12 to 16 weeks into the postpartum period. And on exam, you may find it's kind of a painless, just small, non-tender, but firm goiter, okay? And interestingly enough, these people will have an absence of those eye signs, those protuberant eyes, that proptosis and the pretuberal myxedema seen in other forms of hypothyroidism. I put a question mark here, painless thyroiditis. Renal thyroiditis may not actually be painful, but it is considered to be autoimmune. So this is, these people are going to present as usually an elderly or a late middle-aged female, and they usually will have symptoms related to multifocal fibrosis of their system. So oftentimes the thyroid gland will be asymmetric, hard and adherent, and the symptoms are associated with local compression. So signs would be dysphagia, dyspnea, pain, a hoarse voice. The physical exam oftentimes is actually described as wood-like and fixed, okay? And technically painless goiter, but again, if it's compressing nearby structures, you can have some actual symptoms of, so it might be difficult to swallow, some dysphagia or some tracheal compression, okay? Okay, so how do we go about diagnosing thyroiditis? There's a lot of different disease states of the thyroid, right? It gets very overwhelming. Well, let's just keep it simple. So everyone, we need to establish if there's any thyroid dysfunction, right? So TSH, free T3 and T4, okay? So thyroxine and TSH, we'll start with that. If the TSH is high or low, we have a problem, right? So if we have a history, a patient presenting with a history of postpartum induced thyroiditis, we can get some antibody levels, okay? If we're suspecting Hashimoto's, or just as a general, they have some other autoimmune diseases and we're suspecting an autoimmune cause, we can go ahead and draw some antibodies. So those are the anti-TPO antibodies and anti-thyroglobulin antibodies, okay? Thyroglobulin, remember, is a protein made by the follicular cells of the thyroid gland, and it's used by the thyroid gland to produce T3 and T4. So if we've made antibodies to that protein, then it's going to cause alteration in our function of what our whole purpose of our thyroid gland is, which is putting out T3 and T4. If they're coming in with a painful thyroid, okay, they're febrile, we want to obtain some inflammatory markers. So we're doing our CBC, get our white cells. Maybe we need to do a strep test since there is an association, ESR and CRP. In terms of procedures, not many are needed for thyroiditis. We may need to do an FNA if we find a nodule, okay, or an IND if we are suspecting an infectious or suppurative thyroiditis. Other diagnostic tools include imaging. Our ultrasounds are inexpensive and they are a great way to distinguish thyroiditis from multinodular goiter or thyroid nodules, and we can also help to distinguish Hashimoto's from Graves, because Graves classically has an increased vascular flow and our thyroiditis has a decreased vascular flow, okay? Radioactive iodine uptake can be helpful because most of the time thyroiditis has a decreased uptake, okay? And PET imaging can be helpful, if we're looking for discrete nodules or we're suspecting some malignancy. And there aren't really any other invasive diagnostic tests, CTs and MRIs really indicated. So how do we go about our diagnostic workup? I'm going to now pair diagnosis and treatment with each of the types of thyroiditis to try to help us keep our brains kind of wrapped around each type, because they all have a little nuance. So in terms of our painful or inflammatory thyroiditis, this person's coming in with that very painful, enlarged, tender thyroid, right? Diagnosis is primarily clinical. We can really base it on our physical exam finding, and then we want to send off our thyroid test. So this is going to be our free T4, T3, and TSH, okay? We can also get a radioactive iodine uptake to confirm the diagnosis, and patients will really usually initially come in with more hyperthyroid type symptoms. So obviously then our TSH will be low and our T4 will be high, okay, because that negative feedback. These people in a subacute course can become transiently hypothyroid, which means then you'll find a low, high TSH and a low free T4. So all these patients, we measure TSH, free T4, free T3, and then we want to obtain an ESR and a CRP level. So those are our inflammatory markers, okay? And then if we're having difficulty, we can obtain an radioactive iodine uptake test, okay? This is super obvious presentation. You don't need to go that far, okay? You could obtain a Doppler just to help distinguish this from subacute thyroiditis or Graves' disease. Okay. Sometimes we need to obtain ultrasound if we suspect there's an underlying abscess or something that needs to be drained, in which case then you do an FNA with a gram stain and culture, and you start them on the appropriate treatment. So treatment for these people are going to be NSAIDs. So aspirin actually is the first line and drug of choice. However, you can use other NSAIDs. So that will treat that will make them feel better instantly. And if this is a severe form, then corticosteroids and a beta blocker in that acute hyperthyroid phase can be used. This is, again, pretty self-limited process. Rarely do people end up in a permanently hyperthyroid state. You do want to follow these folks up with labs, though, even after their symptoms have resolved, their fogginess, that tenderness has resolved, just to make sure that we're screening for that. And then, of course, antibiotics if this is suppurative. So diagnosis and treatment of Hashimoto thyroiditis. Again, we're going to start with our TSH and free T4. And if we have a suspicion because of other comorbid conditions present, they have diabetes or other autoimmune or family history, we are going to get some autoantibody testing done. Okay, so earlier in this disease, these autoimmunes, they kind of states, they have a hyperthyroid state and then a hypothyroid state, okay, and then eventually euthyroid state. So early on, we'll have we could have normal labs, normal TSH and T4, and then as the T4 lowers, we have more infiltration of this thyroid gland, our TSH will start rising. Most of the time in Hashimoto, we will have a higher anti-TPO antibody compared to anti-thyroglobulin antibodies. An ultrasound is must be done. Actually, it's suggested in some literature. I would ultrasound all of these people because of the relatively high rate of associated papillary thyroid cancer. It's 8%, okay, if there's a nodule present. With our general populations, not everyone has the easiest exam with, especially if somebody's obese, so it's just safer to get an ultrasound. Again, it's cheap, doesn't involve radiation. And we might want to think about testing for other autoimmune disorders. In terms of treatment, we are going to give thyroid replacement therapy. So this is your levothyroxine, and this is going to be usually between 75 and 150 mics daily. You might need to start with a lower dose than that. If they're thyrotoxic initially, PTU or propranolol, beta blockade. And generally speaking, a lot of these people end up needing lifelong replacement therapy because they never really end up coming back to that euthyroid state. So in terms of silent or postpartum thyroiditis, I tend to group these together because they have a similar mechanism, similar treatments, similar presentation, aside from the postpartum part in men. So our diagnostic workup is going to be screening. Now, if a patient has a history of postpartum thyroiditis in a previous pregnancy or even after a miscarriage, you are going to screen this person after every single pregnancy, even if they're asymptomatic, because they're high rate of recurrence. Okay, so again, we're going to just start with our regular thyroid hormones, okay? And these are going to vary with our stage in our illness. So if they're in the thyrotoxic phase, we are going to have that low TSH and high output of free T4, right? And if they're in the hypothyroid stage, then again, they're going to have that high TSH and low T4, okay? So our anti-TPO body can be a good marker for prediction. So if somebody's had previous postpartum thyroiditis, we can draw this. And so we just need to keep a close eye. So if it's positive, we're going to be measuring that TSH at 6 to 12 weeks of gestation, and then at 6 months postpartum, and or as clinically indicated. And we will, if we obtain an ultrasound, which we will find that there can be a variable texture. It's going to be relatively hypoechogenic. There's really similar laboratory findings in the silent or painless thyroiditis, the subacute lymphocytic type, but it's a little bit shorter of a course. So these people aren't going to kind of have this longer hypothyroid phase. They'll become euthyroid usually much less than a year. And about 50% of these people also have anti-TPO antibodies. Our treatment will be conservative. We want to use beta blockade in that hyperthyroid phase, and then thyroid replacement if they are symptomatic in the hypothyroid phase. And then in our postpartum type, we want to reevaluate after about a year of treatment, because 80% of these people will have normal function at 1 year. You'll want to screen them moving forward because there's a 7-year risk of hypothyroidism at about 50% of these people. Okay, so that's pretty high. There is some suggestion of dietary supplementation with selenium, and at about 200 mics per day, it can reduce your serum levels of TPO antibodies. And in pregnant women with the autoimmune thyroiditis, even lower doses at 83 mics per day. There's been some studies showing that it reduced the usual rebound postpartum increase in those antithyroid antibodies without side effects on the mother and newborn. But I will note that the clinical impact, the global clinical impact, really is still kind of really not known. In terms of the renal thyroiditis, again, you're going to start with your TSH, free T3, T4, and is going to be consistent with a hypothyroid state because of the extensive replacement of the gland by scar tissue. Okay, these people will have anti-TPO antibodies most of the time, and they will have a very low uptake of radioactive iodine because we're not making any thyroid, right? We have replacement of glands by scar tissue. So that's the reason why you have low uptake because we are not converting our iodine, right? We're not uptaking iodine, and we have a very non-functioning thyroid gland. So occasionally these people need an open biopsy to confirm the diagnosis, or just to decompress surrounding structures. Okay, if the treatment, if this is IgG4 related illness, tamoxifen, believe it or not, and it's actually the MOA of this appears to be unrelated to anti-estrogen activity, although I find that interesting considering that this is usually women with these disease states. But corticosteroids may be helpful if they're having some compression or local inflammation, pain related to compression, and surgical decompression as indicated. In terms of complications of thyroiditis, we always want to consider the possibility of carcinoma or lymphoma when we feel nodules. We must rule out nodules and keep a close eye on people with Hashimoto's so that we don't miss an early conversion to thyroid cancer, right? Hashimoto's complication, the main one is that it has a very high rate of permanent hypothyroid state. And women with Hashimoto's thyroiditis are at a very high rate of risk of spontaneous abortion in their first trimester. So we want to be, if they are going into that phase of life and they are trying to become pregnant, we are going to be replacing thyroid hormone even at a euthyroid state. Okay. Do note that people with high levels of anti-TPO antibodies, interestingly, these are associated with higher risk of depression in the hypothyroid state. In terms of suppurative, this is obvious. This is an infectious risk, and if you have an infection or an abscess, this can be compressing surrounding structures. We have a lot of important structures in our neck, right? And then renal has, again, compression of structures, and vocal cord palsy can be a big problem. So I have a little summary for you. Hopefully this wraps it all up very quickly for you, and resources, of course. Have a great day.